Hey, is anybody on?
We haven't started yet.
Hello?
I'm here, Flo.
Oh, it's me, Miss Buckaloo. It's Nicole.
Oh, okay. Hey, sorry.
I'm gonna call you on your cell. I got an emergency.
You're gonna what?
I'm gonna call you on your cell phone. I have an emergency.
Okay. All right. Everyone should be back. All right. Let's start going over the exam. So anything that has jumped out at you in the last 15 minutes while reviewing?
I think for me was just most of mine were from that table that obviously I didn't go over enough. Table 47.
Yeah.
Was that table 40, 47, 8?
Yeah. Okay.
Because I think most of mine were, every time I was like going, checking, most of mine were up from there. And I think there was one that I just didn't like understand because I read what it was and I guess not really. And a lot of them, of course, and then the other ones, of course, getting that accept.
That was the same thing for me, except
Yeah.
in a lot of mine that I missed. I guess I didn't read
Yeah, like
as
kind
closely as I should have. Because now going back looking at it, I know the correct answer to it. I just the accept part.
Okay.
Or even that little bit of anxiety taking the test, you know. And then I think like two of mine were like the one that was the right answer was, you know, when you're compare, you know, going through your answers and picking what's not and process of elimination. I saw that the correct answer was my 50 to 50.
Yeah, that was the same. That was the same thing for me, Flo.
I was like, man. I think it's
Because none of them are like out of the way to me. Like I know all of them. None of them look foreign. All of them look familiar. So I know it was my mistake. Like I don't need extra explanation on any of them. It was just the accept or not reading as good as I should have.
Yeah.
Okay. All right.
Nervous about the test and making sure, like, you know, knowing that you're reading it over and that little bit of anxiety is like, you know, because when you're really relaxed, like now when you're looking at the answer, you're like, oh my goodness, like really, I know this, you know? And so I think for me, sometimes even rereading it, I'm like, you know, and then I kind of, I'll read it 2-3 times and at that time I'm not getting it, but then when you're more relaxed, you read it and you're like, duh. So, for me too, I'm 19. I think, is it 19? Yeah, like I didn't, the answer that I chose had all 3 of them. So for me, it was saying when you're considering the weaning and an up-tuned patient, for me, I'm looking at it as like, I don't want them on drugs that are going to depress their ability to try to, you know, take those deep breaths or, because I know it's the adequate, I knew the gag reflex and their cough. But my whole thinking was also, okay, well, I don't want no drugs to depress them. You know what I mean? Like if they're like taking them off the sedation medication and stuff like that, I don't want something to depress them.
Okay.
So that was my whole thinking of that. And so it wasn't that.
All right, with that one, it's specifically referring to the obtunded patient, and some of them you can't take off of, and just some people you can't take off of all of their medications. So,
Okay.
it said no depressant drugs. So if it
Okay, I
had
see.
said wean down, turn down, decrease, something like that, you could have included that one. But
Okay.
because it says none, that
Okay.
was your key to that one. Because
Okay.
you can't always take off all of their pain medications. You can
Okay.
change them, you can make them more mild, but if you were to take them off of it and you have somebody who they can't respond to pain in any way but increasing their work of breathing and that kind of thing, well then it's going to backfire on you.
Okay. Okay. I guess that was that whole kind of my thinking of like, I don't want them, you know. Okay.
Right. Okay.
I think everything else, like we just spoke about, was, you know, not really reading into and really reading everything to know the exact, or even to know exact, you know, you have to know what they are in order to pick out the except. And so, you know, kind of going over and, you know, going, okay, maybe I'm taking too long on this question. And then, you know, going over it and then just, you know, rushing to just get it done. Maybe that. But then also, like I said, that same chart, you know, the table of,
All right.
and then I guess this other one on 24 of, you know, that this was one of my 50-50, but then, you know, thinking of why do we do pressure support? And it's just to like have them overcome that imposed workload, you know, like that. So of course I know that we want to get them to that title volume, but my whole thinking was, what does pressure support mean? And that's like giving them that oomph. So I guess that's what was my thinking in there, and not really reading into what they're asking.
Okay. All right. Well, if no one has specific questions, I want to get ready for your exam too. So I gave y'all some extra time with us not having it this week, but I do want to go ahead and knock out the study guide. I told y'all I want everyone to participate, so I'm just going to kind of go down the line and go through these questions. So if you will get out your chapter 2 or exam 2 study guide for chapters 34 and 53, we will start going over those. And I'll give y'all a minute to get that out. And Amanda, we will start with you on number 1.
While we're waiting for them to get everything out, Ms. Buckler, one of the assignments that was due this morning, it was the revised title for our presentation. Did you give us comments anywhere on our titles or not? Because I didn't see anything or have anything to revise it, so I didn't know what's up.
Yeah, there should have been.
Because it was one of the things that we had to email you because it wouldn't let us upload.
Okay. If you weren't able to revise, let's get to that. But right, you should be able to upload those. If you didn't in week 2, it's still open. So go back and add those like I asked you to. So all I really wanted was, and I didn't see any issues with anybody that were submitted. I want you to kind of go in and elaborate, like getting ready for your outline. So what are some key points that you know you want to talk about? In the revision, you can also maybe add one of your references, or if you have questions, things that you haven't been able to find, you can add those. It's fine if you haven't done it yet and you want to get those in today, that's fine. But it's just more of an elaboration to make sure that you are taking the steps and adding to this weekly so that we're not doing these presentations all at the last minute and you're getting the most out of it.
Okay.
All right. Okay, so Amanda, identify what the first clinical sign of RDS is in the newborn.
I got tachypnea, distal flaring, audible grunting, and paradoxical breathing. And fine inspiratory goals, and I found that on page 690.
Okay. Very good. Correct. So it said on 690, like she was just talking about, the first signs of respiratory distress in infants with RDS normally appear soon after birth, so very quickly. Tachypnea is normally your first sign or clinical manifestation of RDS. Along with that is retractions, paradoxical breathing, audible grunting, and nasal flaring may be seen as well. So your first one is always the tachypnea. Number 2, Andrika, identify the diagnostic parameter that is most often used to confirm the diagnosis of RDS.
I have chest radiograph, chest x-ray.
Very good. And what exactly are you looking for? What does that x-ray look like?
Bilateral infiltrates.
A little bit more specific than that. You're looking for retrogranular densities and air bronchograms.
Okay.
They also typically have low volumes. And the examples are on 690, and the explanation for that is on 690. AJ, number 3, identify the progression of steps to take when caring for infants, primarily infants with RDS, who also begin to deteriorate with severe hypoxemia and increasing FiO2s.
I've got endotracheal intubation should be performed under controlled conditions as an elective procedure. Mechanical ventilation with PEEP should be initiated if oxygenation does not improve with CPAP, or if the patient is apneic or acidotic.
Very good. Where did you get that information?
Page 690.
Very good. Quick notes. First steps are to try that CPAP, low CPAP of 4 to 6. And when that doesn't help, then you would move to endotracheal tube or using nasal prongs through like a non-invasive mode. Okay. But if it is aggressive, if they are rapidly deteriorating or aggressive treatment is needed, then you would go straight to the intubation. All right. Flo, what is TTN?
TTN is transient tachypnea, newborn, type 2 RDS, most common respiratory disorder of newborns. That was on page 691.
You are now muted.
Hello, there's 4 of you. Does that mean you get to answer the next 4 questions? I'm just kidding. Mallory, number 5. What's the cause of transient tachypnea of the newborn?
You are now unmuted.
Oh, it looks like hers is not on. Right?
Yeah, she's got that white circle.
Yeah, that clear circle. I guess they got logged off or something.
Okay.
Kicked out.
All right. Taylor, what is the cause of transient tachypnea of the newborn?
It's unclear, but it's most likely related to delayed clearance of fetal lung liquid, most common in C-sections.
Okay. And can you tell me why they don't, what is it that causes C-section babies to have this versus babies born vaginally?
When they're born naturally, they have the squeeze that squeezes all the fluid out, I guess. And then with section, there's no squeeze, so.
Very good. So they don't have that thoracic squeeze through the birth canal that causes reabsorption through the lymphatic vessels during initial breathing. And also, like I said, it's almost like when they get that squeeze, it's like their body's like, hey, they're going to the world, so to speak. So it causes that change for them. And when they're born via C-section, they don't have that. So they have to make that adjustment on their own. Okay. Shara, identify the best form of treatment for lung fluid clearance in an infant with transient tachypnea of the newborn.
That is frequent turning low FiO2 by infant oxygen hood or nasal cannula for higher FiO2 use, CPAP, in page 692.
Where did you find that?
Can you hear me?
I can. I said, where did you find that?
Page 692.
Right. Let's try to see if there's something I want to add to that. Right, so a couple of things about the treatment. One of them is they are commonly treated with antibiotics because it looks like pneumonia, and because we don't have a way to quickly differentiate between the two, they oftentimes will go ahead and give them antibiotics as well. And then, like I mentioned, pressure, positive pressure does really well for them. They typically do this because it causes that push, just like if you were to have an adult in fluid overload. So treating them like that. All right. Right back to the top, Amanda. What is meconium aspiration syndrome, or MAS?
All right. Inhalation of fetal fecal matter into the central airways of the lungs.
Right. What babies are more likely to suffer from meconium aspiration syndrome?
Babies that are for their due date, so over 40 weeks.
Very good. Andrika, identify the 3 primary problems for meconium aspiration syndrome.
Pulmonary obstruction, lung tissue damage, and pulmonary hypertension. And I got it off of EGAN 692.
Very good. AJ, identify what is associated with What is associated with ball valve obstruction in meconium aspiration?
Obstruction occurs because of plugging of the airways with particulate meconium. The ball valve type allows gas entry but prevents gas exit, causes air trapping, and can lead to volutrauma.
Very good. And that, along with your image, is on 692 as well. Hello. What is bronchopulmonary dysplasia and what is implicated in the origin of it?
Chronic pulmonary condition that affects infants, especially preterm infants with severe respiratory failure, immaturity, genetics, malnutrition, O2 toxicity, mechanical ventilation, and all have been suspected to cause BPD, bronchopulmonary disease.
Very good. So out of those, immaturity and genetics are pretty much the only ones that we don't control. Malnutrition, we should be feeding these babies properly. We can watch our O2 and we can be careful with our mechanical ventilation settings to some extent. So watching those high pressures, making sure that we're elevating care. If we still have a PaO2 of 60 or lower and we're already on FiO2 of 60, well, then we don't need to leave them on high flow. We need to put them on CPAP or we need to intubate them, that kind of thing. So elevation of care when needed is important to note with that. Mallory, still not on. Okay, so Taylor, identify the treatment strategies for the premature infant with apnea.
You skipped 11.
Oh, did I? I'm sorry. What is the best strategy in the management of bronchopulmonary dysplasia? Sorry.
Prevention, page 694.
Prevention of what?
Adult trauma and volutrauma.
Correct. So making sure that in that first few minutes of life that we are establishing that FRC so that they have some kind of reserve is really important. And also early use of surfactant. Now we're at Tashara, sorry about that. Identify this treatment strategy for the premature infant with apnea.
That's on page 695. Infants with apnea need continuous monitoring of heart and respiratory rate, CPAP monitoring of oxygenation by transcutaneous electrode or pulse oximetry. First, underlying cause if identified stimulation have aeopin or caffeine or transfusion.
All right. So if we look at table 34-3 on 695, you have all your treatments and why we do them. Make sure that you look at that, kind of expand on what the Shara just said. And notice that there are 2 different drugs, oxypram and theophylline or caffeine, that are both used in the treatment of infants with apnea. Up to Amanda. What is PPHN and identify what is it? What is its cause? So identify what it causes.
PPHN is persistent pulmonary hypertension of the newborn and is commonly caused by elevated PVR.
Okay. And that elevated PVR is due to the return of fetal circulation. The 2 correlate together, which is a right to left shunt, and it presents with severe hypoxemia metabolic and respiratory acidosis. All right, I know there's about to be, the next question is on the treatment of, but I want to talk a little bit more about this with that fetal circulation. If you read on to the second paragraph of it, it said, in the uterus, the fetus does not use the lungs as gas exchange organ. The PVR is high and your SVR is low. So you have shunting going on, and that shunting has to change once they are born. And when that doesn't happen, it can cause PPHN. In the transition to extrauterine life, PVR decreases, allowing for the lungs to start working, increasing their PaO2, and increasing their pulmonary and venous circulation. The next one is Andrika, which is identify treatment strategies for PPHN.
Okay, that's number 14. Okay, I have increased pulmonary vascular resistance. Causes is elevated PVR, removing of underlying cause, hypoxemia with O2 and surfactant RDS, ECMO, high flow, and nitric oxide, not caffeine, on Egan 696.
Okay. Very good. Can somebody tell me why high frequency ventilation, what that does, and why it works so well with your kids or babies with PPHN?
Is the high frequency ventilation the same? Is that the one that, is that the same as like the oscillation ventilation?
Yes. Yep.
Okay. So it, I remember from class and reading, I think with the vibration, they kind of, I have it in my head, I just can't say it. Like,
All right, so they're getting these really large respiratory rates and these really small tidal volumes. So because of that, it's really increasing their FRC, what remains in their lungs, right? The residual capacity. So it's creating a higher FRC without having the large tidal volume, and in return can increase their oxygenation better. And then, if, of course, if that doesn't work, like she said, you can move to ECMO. All right, so we should be on 15 with AJ. What is congenital diaphragmatic hernia, or CDH?
CDH is a severe disease that usually manifests in newborns as severe respiratory distress, a complex combination of lung hypoplasia, including decreased alveolar count and decreased pulmonary vasculature, pulmonary hypertension, and unusual anatomy of the inferior vena cava. 697.
Very good. Flo, identify the clinical findings associated with CDH.
We're on 16. Okay, right, we're on 16. The skyphoid abdomen and decreased breast sounds and severe cyanosis.
Okay. Very good. I do want to elaborate on that a little bit. So, this can be seen or is normally diagnosed with ultrasound. Okay. There are two different types. The lateral and posterior defect, which is usually on your left, and then the medial and anterior, which can be on either side.
And okay, so I looked this up because I didn't kind of understand that.
Mhm.
But I saw why, and I'm like, why is it so depressed? And it's because, of course, if you see the pictures, and once all of the intestines and everything tries to go through the, I guess, well, what is it?
You are now
The
muted.
depression or the hole or foramen.
Mhm.
You are
And then
now
I was like,
unmuted.
oh, duh. You don't have anything in there. Everything is going through the hole. I was like, okay. Because I didn't understand it. I was like, what does that mean? And so, going through and really seeing it, then I was like, oh, okay, I understand now.
Very good. I do want to also note that if it happened on the right side, it's not as severe, and that's because you have large organs over there that kind of block it and help keep some of that down. So the ones that happen on the left tend to be more severe.
Yeah, because that one pulls everything through.
Long term, if we're able to correct this and they do well, one thing that typically happens that does long term affects respiratory systems or can is scoliosis, depending on how severe it is. And if somebody has severe scoliosis, what kind of respiratory issues are they going to have? Could have.
That would be restrictive, right?
Very good.
Low tidal volumes and
Very good. So long term, if you have severe scoliosis, it can cause a restrictive problem. Next, we have Taylor, number 17. What is transmission of the great vessel, and identify what unfortunate situation it causes for the newborn?
It's a heart disease that most frequently causes severe cyanosis. It usually manifests as moderate to severe immediately after birth. A murmur may be present, and infants with this abnormality frequently need emergency atrial. Yeah, I can't even say it.
So this is one that is immediately they're going to have some kind of surgery. It does say that they're now doing them ultrasound guided, so they're not as invasive, but it does require them to go to the OR or the cath lab. The Shara, number 18. When considering the patent ductus arteriosus, where is most of the blood flow shunted to, and how soon after birth does it typically flows?
In a fetus, most of the pulmonary blood flow is shunted through the ductus arteriosus to the aorta. Closure of the ductus normally occurs 5 to 7 days after birth of a term infant. Patent ductus arteriosus usually is a disease of immature term infant. On page 700.
Very good. And how do we treat that?
Treatment is the pharmacologic or surgical.
Amanda, you're back to you at 19. Identify the congenital defects in which heart transplantation is a viable option for treatment.
I said hypoplastic left heart syndrome. Now that I'm 701. Was there more than one?
That is the most common. And not all of them need a heart transplant, but many of them will in hypoplastic left heart syndrome. I actually have a family friend whose son just last week had a heart transplant due to hypoplastic left heart syndrome at the age of 7. So he has been doing really well. He's on ECMO now. They're hoping to take him off of ECMO today and see how he does on the vent. Interesting story though. He always tolerated his surgeries well. He's had several throughout his life, but always turned around, lived at home, done really well. About 3-4 months ago, he went in for a cath just to see how his heart was functioning and, see where they were on the pathway. And they found some bigger issues than they thought were going on while they were in there, which is why they don't just do an echo. They go in and really see what's going on with the heart. And like I said, found some other issue, decided to keep him in the hospital until they could figure out what they were going to do. While he was there, really very lucky. He was just in his room one day. Nothing had changed from what they would have been doing at home. And he ended up coding. So was fine one minute, was not fine the next. Ended up on ECMO prior to this. They got him off, got him stabilized, got him moved all the way up to Pennsylvania, put on the heart transplant list, and like I said, just last week received a donor heart. Because of all of his scar tissue that he's had from the several open heart surgeries that he's had, he had a lot of pressure in his chest and swelling after surgery, and they weren't able to close his chest, which is oftentimes what happens with newborns because they're so small. When they have open heart surgery, it's not like they have extra skin of any kind. It can be stretched, and they'll leave their chest open for like a week or two to allow the body to kind of regulate, and then they'll close up the chest and they don't have to worry about pressures. And in his case, being older, he's actually the first one that I've known of that they've had to leave his chest open. And so the next steps are, like I said, getting him off ECMO hopefully today, and then maybe closing his chest later on this week. It does happen, and a very neat process, but the medical world is amazing and the things that we can do. Our next one, number 20, goes to Andrika. When considering SIDS, identify the maternal characteristics associated with its increased occurrence.
Okay, I have preterm African-American boy born to a poor mother younger than 20 years old, inadequate prenatal care, prone sleeping position, and mother smokes. And that was on Egan 701.
Very good. There's also a box on 702 that goes over the characteristics of the actual child. Said infant characteristics near the time of death from sudden infant syndrome. Most of them are younger than 6 months. The peak is between 1 and 3 months of age. Happens more often in winter, at night. It normally has some kind of mild illness the week before. We talked about the history of apparent life-threatening events and what those are last week. Sleeping prone, and again, the mother smoking. Right. Now we are at AJ 21. What is bronchiolitis, and identify its typical findings?
Bronchiolitis is an acute infection of the lower respiratory tract, usually caused by respiratory syncytial virus, RSV. A chest x-ray shows signs of hyperinflation with areas of consolidation, inflammation, and obstruction of the small bronchi and bronchioles. 702.
Very good. So RSV, a couple of other things that I want to add to it. Let me see where I can find it. Anybody know what medication we use to treat RSV? I say we use it, but we really don't, but you need to know it. It's still on your exams. Not necessarily this, but in your board exams, they still test on it. Anybody?
Liquid albuterol?
No.
Oh, that's what my son got.
It is actually ribavirin. I remember learning about that in 210.
Is that the one that's used as a respirator?
Yes. You have to use a spag to deliver it. Okay. It is used for.
Sorry, I was thinking of the bronchiolitis, not the RSV.
Yeah. Oh, I'm sorry. Yeah. So caused by the RSV. So, yeah, I should have been more specific on that, but that is something, that drug, you do need to know when it's given. So for RSV and how it's given through the spag. Okay. So like I said, and we don't really do it in the hospitals for a couple of reasons. It's an expensive drug. It's hard to give because you have to give it with a spag. You have to do reverse isolation. You have to have all these extra filters, and it's not very effective. They found that it doesn't decrease the amount of time that they're sick. They still have long courses. Like I said, RSV is about 2 weeks, generally speaking. So it doesn't shorten your course. And there's other things that we can do to treat the symptoms, because you're not really treating the virus, because just like the flu, you get rid of that. So there's other things we can do. So racemic epi if they have stridor. We can give them Tylenol if they have fevers. We can give them albuterol if they're wheezing. So there's other treatment courses that are just as effective, and that's why we don't do it as often anymore.
Isn't the if I might be getting mixed up, but isn't this one medication that we can't be in the room for? We have to keep it and leave.
So if you cannot leave the room, it's gonna have filters, and again, you would need to wear like an N95 mask.
Okay, I was like, I know there was one, and I couldn't remember if it was for this one or if it was for the.
Yeah, you have to.
We can't even be there. Like, we're supposed to be in the room, we're supposed to leave, or the N95s, because we can't breathe in the medication. I was just trying to correlate, making sure I had to put in the same box.
Yeah, you should not be in the room, but if you had to be, if it was being given in a closed circuit and you had to be in the room, you should still wear an N95. Who was that? Andrika answered that one?
I'm sorry, did you say my name?
I think so.
You were the last one to go, right?
Yes, ma'am.
Okay, so, all right. AJ, identify the radiographical findings that would suggest croup and epiglottitis.
Actually, I just did 21.
Yeah, he just did 21. That's what
Yeah, sorry.
he did.
Okay, sorry, Flo.
Oh, for 22, it's an X-ray of croup. It's going to show that classic steeple sign, and for the epiglottitis on the lateral radiograph, it's going to show the thumb sign.
Okay, so make sure you can identify not only what sign it goes with, but what type of X-ray. So, anterior, posterior, chest X-ray.
For the croup is the chest X-ray, and for the epiglottitis is the lateral.
Correct.
Lateral.
So, correct. It's going to be a lateral or side view of the neck for epiglottitis, because you cannot see that thumbprint from a side view X-ray.
You mean that's the only way that you're going to see it?
Or yes, that's the only way you can see it. You can't see it from like a regular chest X-ray. Sorry.
That's okay.
And you said croup was anterior, posterior?
Yes. Yep. And you can see it, that upper airway swelling or subglottic narrowing is sometimes how they word it. All right, after Flo, no Mallory, Taylor. Identify what is the primary reason for the decline of epiglottitis over the past decades.
Vaccinations, page 704.
Very good. And I think I mentioned that, so get your flu shots. Okay. Bashara, identify clinical findings typically seen in patients with epiglottitis.
High fever, sore throat, stridor and labored breathing, and for older children is sore throat and difficulty in swallowing in page 704.
Very good. And they may present in looking like they're very concerned and drooling. And now back to Amanda. Identifying the clinical findings typically seen in patients with croup.
Group B, nasal congestion and cough, stridor, and a barky seal-like cough.
Okay, very good. What is RSV? Can somebody tell me some of their clinical signs? Bronchitis.
I have a slight fever, cough, dyspnea, tachypnea, progressive inflammation, and narrowing of the airways, inspiratory and expiratory wheezing.
Good. They do tend to wheeze. They're very, very congested. Lots of nasal secretions. For these little guys, they often need nasal suctioning quite often. Especially the small. They can't blow their nose.
Between RSV and group would be the barky cough.
Yep. So with croup, it is termed laryngeotracheal bronchitis. So they do present pretty similar. Okay, they're both viral. But with croup, you can have both of those at the same time. Okay. Croup is typically children that are 6 months to 6 years old. The RSV is actually younger than that. Typically 1 to 2 will get that, sometimes younger. But the older they get, the less likely the RSV is. Where the croup, they can get that up to about the age of 6. I have seen some older kids with it, but it's just not as common. Normally got some kind of herd immunity built up by then.
My son had croup. It was scary.
Okay. All right. So we are done with chapter 34. Any questions about any of this material?
No, I think it's very explanatory. It's just the memorization of the different symptoms for each thing. And then, like, when you went over it in class, the PowerPoint, it really made it was being read and Egan, because it is not supposed to touch with all the time. It made it click easier. So even when I did the study guide, it made sense.
Good. Yeah, one of the main reasons that I gave you all this extra time with this pediatric stuff is because, like I said, I don't want you to just learn it for the test, because they're ultimately, one, you need to know them, and two, in just 15, 16 short weeks, y'all are going to be taking your board, and I can guarantee you a couple of things. You're going to have an asthmatic child, you're going to have a heart defect child, you're going to have either epiglottitis or croup, or RSV, one of those types. So RSV, croup, epiglottitis, you're gonna have one of them. And you're probably gonna have a cystic fibrosis kid. So out of your 22 SIMs, there's at least 3 of those are going to show up. And maybe 4, because they might give you an adult cystic fibrosis patient, but they're still going to give you some of the manifestation stuff that you learned from this chapter. So it's really important that you understand how to identify these and how to treat them. Okay? So that's why I wanted to give you all the extra time. I really don't want you to learn it and dump it, so to speak. So, all right, let's take, since we're moving on to the next chapter, let's take a 15-minute break, and then we'll come back and do chapter 53, okay?
All right.
Thank you.
Yep, see you in a few.
You are now muted.